this up like this, I knew how important training was. And also like that integration of taking a patient who might be done with your treatment plan with traditional work that we do, and then how to integrate that into the gym setting. So
definitely. So, you know, continuing going on, here, I'll move my thing out of the way. So Gestalt education is kind of what we, this is basically why we started in the first place. So Brett said this quote, and it stuck with me forever. It says, students are drowning in information, but are starving for application. In other words, I was one of the seminar gypsies, right? So I went to every single seminar on the weekend. I went to every club. I was enamored with learning, but I had no clue what the heck to do when I stepped into a treatment room. And so that's what started my passion of trying to learn the integration piece and figuring out what to do with all this information. And so that's hopefully what we're trying to accomplish with Gestalt education, is to not only give really good information, but also how the heck do you do it with a patient in front of you? And so it's not easy. It's a lifelong learning experience. I'm sure that Brett can attest to it. Lauren and I are still, we're still figuring it out. So every single day is different. But so that's kind of the backbone of Gestalt education, and kind of why Gestalt in the first place is that it kind of feeds back into that education integration. And so the meaning of Gestalt is an organized whole that is perceived as more than the sum of its parts. In other words, you're only as good as your parts, but you're only as good as your parts combined. And so it's no different in the treatment room. It's no different in life in general, I think, is that being able to integrate multiple different schools of thought and multiple different ideas into one kind of is the name of the game. So,
or the thought that maybe a separate tool outside of whatever technique that we're talking about might actually enhance that technique. For example, if you are talking about McKinsey or MDT, your ability to adjust someone's CT junction, for example, will only make you better in MDT, because now we can get the lower cervical spine segments into more end range, or whatever the example might be. You could use the same example for DNS. If I can get the segments into a better position with manipulation, for example, then my DNS technique is made better by that. So I think it's important to not get stuck into, only one way of thinking, and then being able to integrate all these different ideas together is really where I think where it's all at.
Yeah, I agree, 100%. So that kind of takes us to, this is kind of our functional triage. And so no different than if you walked into the ER today with a chest pain, right? So you would see the function or the triage nurse, and she's going to basically try to figure out what hospital you need to be in. In other words, is that chest pain coming from indigestion? Is it coming from an actual heart attack? Do you need nitroglycerin right away? Is it just an anxiety attack, anything like that? So you wouldn't walk into the ER and they wouldn't shove down 3 different things or 3 different treatments to treat all the things it could be. We want to try to triage it and narrow it down to the specific things. And so the top 4 are kind of like our operating system, if you will. Those are the things that pretty much every single treatment, every single patient that walks through the door is going to get some aspect of these, or whether that's assessment, treatment, any of those things. And then the bottom ones are kind of just our fillers. Maybe it's not 100% of the time, but it still plays a really, really big role in certain specific areas.
So the only way to navigate through this also is through really good assessment. So if you don't have an ability to assess your patient well, then your ability to be good at triage basically becomes impossible. And that's not the mistake, but the thing I would have to say that, students and doctors make on a continual basis is they don't assess the patients well. And then when they reassess a patient, they're not good at calling an audible and saying, okay, whatever I was doing is not working. I need to switch gears. And because of that, they're kind of either they don't get the desired result, or it takes them a long time to get the result that they want.
Definitely.
So there's plenty of research to support us. For example, if we're talking about the shoulder, just doing manual therapy around the shoulder. So I always include this slide just to remind you that this is the Braunford report, by the way. So this just kind of goes through all the different extremity complaints, and from a research standpoint, the benefit that we can have just by doing work around the extremities. So if we talk about manual therapy to the extremities, it's difficult to find people who are really, really good in the extremities if we're talking about manipulation. So but I would also say, because I think the schools sometimes, like we want our students to get good at the spine, and then the extremities kind of become an afterthought. And because of that, we're not as good in the extremities probably as we should be. So I would just, say that, the manual treatment, the manipulation of the extremities is really important, and then integrate it into the rehabilitation world. You're going to find now that every piece of research, whether we're talking about the low back, cervical spine, shoulder, foot, and hip, they all will support a multimodal approach to treatment, which basically means whenever we're able to integrate therapeutic exercise in with manual therapy, we'll always get a greater outcome. Always, whenever they look at it, that's basically where it's all headed. Okay, so if we look at the shoulder is just a really unique joint. So it's the second most unstable joint on the body. The TMJ would be number one, but the shoulder is number two. And so whenever we have a joint like this that is grossly unstable, we're heavily reliant on the soft tissues around the shoulder. So you can see here, if we look at the marble in a bowl example here, if you look at B, that's basically what the shoulder is. So the bigger the neutral zone, the more we're reliant on muscles, ligaments, and soft tissues to help stabilize our shoulder. So in saying that, that also makes it a greater risk for dislocation, which is, I'm sure you've learned already in school. One thing that is a common injury that we see, especially in the younger athlete, is shoulder dislocation. And I'll talk in a second here about what that means as far as treatment and things like that. But it's a miraculous joint. However, with all that mobility comes the risk of instability and dislocation. So it's been likened to, some people say it's like a golf ball sitting on a tee. Other people have said it's more like a sea lion balancing a ball, which I like that example better, because basically you have a dynamic situation where you have the nose trying to control the ball, and that is no different than the humerus and the glenoid. But anyway, so this is a very dynamic situation, and in treatment, we do real specific things to try to activate the muscles around the shoulder girdle. So you can see here, it's kind of a complex 4-joint system. Not kind of, it is. So it's basically 4 joints that we're dealing with here. So we're dealing with the glenohumeral joint, we're dealing with the SC joint, and we're dealing with the AC joint. And then you have what's called the pseudo joint, and that is the scapulothoracic joint. And there's a lot of debate right now, honestly, about how important scapular stabilization is. It's been hard to study. It's been hard to prove. For what it's worth, it's a big part of what we teach at DNS. So I'm one who truly believes that scapular stabilization is critically important, but I'd also be the first to admit that it would be a difficult thing to actually put numbers to and study. But I think that is it's a very important thing that we're always working on with our patients. And usually we are using the DNS principles and methods to help us with that. So you can see here, if we just look at the anatomy of the shoulder, there is on just an average shoulder, you're going to have some degree of retroversion. So, and then you can see, if you look down at that picture on the left there, you'll see that there is actually external humeral rotation also. So you have the retroversion of the glenoid that's there, and you also have retroversion or rotation of the humerus. And this becomes critically important for the throwing athlete. So this is why if some of you were to have young kids right now and you wanted your son to be a professional baseball pitcher, he would be needing to be throwing a ball with the physis and growth plates open. However, there's some debate on like at what point you'd want them to start pitching. So I can name you a couple examples, but not 10 examples of Major League Baseball pitchers who were pitchers at a very young age and just kind of continued it on. The thing that you hear way more often is that they started pitching in high school. So that's interesting, but you do need to be throwing a baseball to get that external humeral rotation with the growth plate. That's why, like, if we brought someone over from Europe and they were 20 years old and we said, hey, I want you to be a professional baseball pitcher, it's probably not even structurally possible for them to do that, because they need to have the years of throwing objects or implements with their growth plates open. That way they can start to get some of that external rotation that we're talking about. Okay, so and in DNS, I forgot DNS baseball. So we talk a lot about with the baseball athlete as far as developmental kinesiology, turning muscles on in certain developmental positions, but also even in the right mechanics of pitching. So if you looked at Juan Marichal to the right there, one key thing to notice is if you look at his humerus here, they can see if I so if you look at his humerus and you look at his femur, you'll see these are in they're parallel to each other, so you can see these are parallel lines, but they're also in the same plane of glass. So what that tells me at this point of throwing is that his time, he's on time basically. So pitching, golfing, hitting, throwing bags, whatever it might be, is it all comes down to timing. So, and that is why, like, for example, in golf, like things can be so right with your golf swing today and then be so wrong tomorrow. And the reason is because it is so easy and common to get timing off. Now, I guess the thing that I'm just still enamored with is how developmental kinesiology never lets us down. So developmental kinesiology always tells me what's right or wrong in baseball, either with the pitcher or I'll explain when we finish up today how that has led me to believe that you can basically bucket the people who are susceptible to UCL injuries just by looking at developmental kinesiology in the baseball athlete. So what about imaging? So I don't know if everyone on this in this group has heard of Dr. James Andrews, but he's basically the grandfather of orthopedic surgery. So he is just a phenomenal clinician, but he's also just a really good person. But anyways, he looked at 31 perfectly healthy professional baseball pitchers. And what he found out was 90% of them had abnormal rotator cuff tendon. So I don't need to tell this group because you already know this, but we need to watch that we don't over image these athletes. More importantly, and Michael Shacklock says it better than I'm about to say it, is that it's not really the over imaging that's the problem. It's the education off of the imaging that's the problem. So what I tell an athlete after I'm looking at their imaging can mean so much to the trajectory of that athlete and their injury. Meaning, if I overdiagnose something in their report of findings on their MRI, let's just say, or their x-ray or their ultrasound, then I am basically creating chronic pain with that athlete. So, and then there's the other side of it too. If somebody's got, a huge structural problem and they require surgery or whatever the next orthopedic intervention is, then I need to be cognizant of that. But what happens oftentimes is people are afraid to move, or they're the thing you hear often is, and I've heard this a million times, is the orthopedic surgeon saying, you have fraying of your rotator, and at some point you're going to require a surgery, but right now you don't. So that is like the death knell to tell an athlete. You might as well just do the surgery now if that's what you said. So I would just sum this slide up by saying, if you've thrown 2 million baseballs in your life, we wouldn't expect your shoulder to look exactly perfect. So some of this is just normal wear and tear on the shoulder. So we got to watch how we educate them. So obviously the gold standard is the arthrogram. So basically we do an MRI with dye, and what we're looking for is to see if there's any leaking of the dye. If there is leaking of the dye, then we suspect a labral tear. The MRI is also really sensitive for any like growth plate issues around the humerus. If there was any other fractures, which is a little bit rare in the shoulder, but possible, it can tell us that. Diagnostic ultrasound, not nearly as good at looking at the labrum than the arthrogram is, but definitely not a waste of time. You can definitely see different issues with the bicep. We can see slap tears with diagnostic ultrasound. It's really hard to make a definitive answer on the labrum by looking at diagnostic ultrasound, but it does have some utility in the shoulder. Plain view x-ray, we can see growth plates, we can see any humeral fractures, but besides that, it's a really, really limited examination of the shoulder because we're not able to see any kind of soft tissue pathology. So I'm not going to say we never use shoulders, but we kind of never use plain view x-ray for the shoulder just because it's a limited examination. Okay, so if you look at the anterior view of a shoulder here on the left, you can see that the capsule of the shoulder and the glenohumeral ligaments are basically blended together. Now, if you look down at the inferior glenohumeral ligament, That ligament at that part of the shoulder is basically like a hammock. So when you abduct your humerus to 90 degrees, that hammock is basically preventing your humerus from basically falling inferior anterior. So, and then not surprisingly, when people have an anterior inferior dislocation of their shoulder, they're almost always going to shred their inferior glenohumeral ligament. This ligament gets repaired when we do a Bankart repair surgically. But so these are important ligaments for stabilization of the shoulder, especially when we get into a vulnerable position like throwing. If you look at the picture to the right, we always reference labral tears to numbers on a clock. So you can see 12, 3, 6, and 9. You guys are probably just used to looking at your phone, but back in the day, I had to actually look at a clock on the wall. But so that's what a clock would look like if you're not familiar. Now it probably makes perfect sense though. If you imagine yourself dislocating anterior inferior, which is what 98% of them are, you're obviously going to shred between 3 and 6 o'clock of the labrum. So when the labrum is torn too, you lose the negative pressure within the joint. That's the other thing that no one ever talks about. That's actually an important point. Is once you dislocate it, the labrum's disturbed and that negative pressure is now gone. So now you're over recruiting all the muscles around the rotator cuff just to try to make it work. So this is why I would say if you are working with someone right now who's a potential, second or first round draft pick coming up in the MLB draft, I would talk to them and their parents and I would say no wrestling. I know it's crazy to say right now because everybody thinks that you should be playing 8 sports. Hey, we do not want you to dislocate your shoulder. Therefore, I'm going to take away all the risk, like basketball and wrestling are the big ones. Because once you dislocate your shoulder and they have to repair this, you still having external rotation in your arm is really not going to be possible. I can't name one Major League Baseball pitcher who's had a Bankart repair and has been able to come back. So, and I kind of disagree with a lot of people on like that, we should, playing for high school. I get it. And there's people that can do that. The problem with that is if we look at players now who are in Major League Baseball, and if we just did a poll, a majority of them are playing baseball from when the sun goes up to the sun goes down. The importance is to vary that sport. So you want to play many different variations of the same sport. But anyways, we want to be careful that you don't, especially if you're a pitcher, you don't have a shoulder dislocation, because if you do, it could be the end of your career. So there was originally by Schneider described 4 different slap lesions. So these were the original 4. That paper came out in 1990. And so no one had really talked about the slap lesion, although when I did a bunch of research on it myself, I found that James Andrews, of course, was actually talking about it in 1985 before, and he never gets credit for it. But anyway, so you can see the different variations, but a slap lesion is basically the distal, the long head of the bicep being torn in an anterior to posterior direction. So these are all, it gets kind of confusing to be quite honest. Later on, Morgan and Burkhart went on to describe other ones and different variations. And we're now actually up to 13 different slap lesions of the shoulder that have been described. So there is many different, variations to this, but by and large, they're all basically the same thing. You're taking the long head of your bicep and you're ripping it off your labrum. All right. So these are just, are we giving them this presentation? Or not? So these are just so you have them, the papers on that. So you can see here, this is the one that I included from James Andrews. This is Schneider, who originally described the slap lesion of the shoulder. Morgan and Burkhart are the ones who, kind of filled the gaps in between all the different slap lesions. And also Moffitt. So if you look at Moffitt's research, he also went on to describe some of the other ones in between the first one and the 13th one. So the Bankart lesion, as you probably learned for boards, that is what happens when we dislocate our shoulders. This is a really common injury. So we're going to try to just only talk about things that you're going to see every day in practice. So, and I'm a proud owner of 2 of these myself. So the downside, well, the good and the bad of this, the bad is once you've dislocated your shoulder, unless you have Marfan's or Ehlers-Danlos, you're always going to disrupt the labrum. So if the patient comes in and says, I've subluxed my shoulder or I've dislocated my shoulder and I was able to relocate on my own, you still in the back of your mind, you know that they probably torn their labrum. So now the question is, what do we want to do with them? So if they're a throwing athlete, I was going to be, doing manipulation my whole life. So to me, it made sense to do the repair. But anyways, you can now probably perfectly imagine in your mind. So when you have a dislocation, the humerus usually will come anterior, inferior, and it will tear the labrum there. And that, by definition, is called a Bankart lesion. And that's what gets repaired during surgery. As it is coming out of the joint during a dislocation, you can see how the bottom part of the glenoid will actually hatchet the head of the humerus. So you were probably taught for boards the Hill-Sachs lesion. So when people have had multiple dislocations, I've had people actually have to do bone plasty to repair the Hill-Sachs lesion because they've dislocated so many times that the bone is actually so disturbed from that lesion there. But so that's just kind of a nice review of what happens when you dislocate your shoulder. If you're I just turned 43 last week. So if I were to dislocate my shoulder again right now, I would probably also tear my subscapularis tendon. So, the old saying is if you take your age minus 100, that's your chance of dislocating your shoulder. So if you're 10 years old minus 100 and you dislocate your shoulder, that would be 90. So there's a 90% chance that you're going to dislocate again. So that's why a lot of times I recommend people get it repaired, because if you're my age and you dislocate again, then your chance of a rotator cuff tear are now really, really high because you're losing the strength and the integrity of your tendons. So the other common thing we see is a rotator cuff tear. Now I know there's a lot of people have been, in many different circles right now saying how we do not need to do a surgical repair on someone who's got a full thickness tear of their supraspinatus. I get that we can allow them to adapt and compensate, but I would argue that if they're healthy and they can do the surgery, I usually always recommend them doing a surgery. It's worth a chance to get this repaired. But you can live your life with a full thickness tear. I've definitely had many, many, many patients over the years that we've just kind of rehabbed them because they weren't able to do a surgery because of a cardiovascular problem or whatever it might be. So sometimes you're basically just stuck repairing them because no one's going to operate on them because they have so many comorbidities. But anyways, Frank Jobe, the famous surgeon for the Los Angeles Dodgers, who's now deceased, but he used to say, fixing a supraspinatus tendon is literally like stitching a stick of butter on an older patient. So it's definitely not, it's not 100% shoo-in like a Bankart repair is, but on the right patient, I think it's worth it to give it a shot, just because once they have that repair, they're able to get back to relative normal activity. So obviously, actually one of the most sensitive and specific orthopedic tests that there are anywhere on the body is the empty can test. So it's a test for strength, but you also have to watch and make sure that they're not showing you any crazy adaptations and compensations. But it's a really good test. And then the lion's share of what you and I are going to see is going to be what would be called shoulder impingement. So you're looking at the side view of a left shoulder right here. So there's 10 millimeters of space between the coracoacromial arch and the top of the humerus. In that space, of course, lives your supraspinatus tendon. So the original theory by Neer, and Neer came out with this in the 1970s originally, was that, when you abduct your humerus, then you impinge that supraspinatus tendon that lives in that area. That has now been called into question by a lot of different people. And so now they're thinking, in the whole movement of how we've changed how we treat people with any tendon problem, is that this is not a pure like pinching of the tendon, because when they look at the degeneration of the supraspinatus tendon, it's actually most often on the underside of the tendon, not on the top side. So that kind of debunks what Neer originally thought, which that the supraspinatus was getting pinched in that space there. So now the current thought process is we should treat the supraspinatus tendon no different than the patellar tendon or the Achilles tendon. So we are going to use eccentric exercise or isometric exercise. It's interesting, a year ago we only talked about eccentric exercise to the tendon. Now we're starting to see isometric exercise, at least early on, kind of be also really, really important in these tendon repairs. But anyways, that's kind of the lion's share of what we see. I forgot to include a picture for you of Shirley Sarman's work. Shirley Sarman always, in her textbook, she always talked about if you have tightness in your posterior capsule here, that it drives the humerus forward and superior, and it disturbs the motion of the joint, but also can cause a pinching of the supraspinatus tendon. My current belief, for what it's worth, is you can have both of those scenarios. So I've definitely seen both examples of that. So one way to know, though, and I actually learned this from Scott Urbawi from MDT, is if you're suspecting the impingement that we're talking about from just like normal tendon, is to actually go into the painful arc with a band loaded exercise. So take like a black TheraBand, and then go to where they're having pain, work in that painful area for like 45 seconds. And then if they go to abduct their arm and they're now 50% better than they were, you know that you're dealing with just like a hypoxic tendon, not a true impingement. If they're truly getting impinged there, then when you go back to that exercise, it should be exactly the same. So that may be a good little clinical pearl, and that's one that I've used, and it works really, really well to help decide, the type of impingement they might have. So how do we make the diagnosis? Well, they have a classic painful arc. So if you look at that slide there, you're seeing they have pain between 60 and 120 degrees of motion. And then they get good when they get above 120 degrees. So that's one way that that we're dealing with shoulder impingement. This is the most common thing that we see every day in our practice. It goes without saying, I don't have it here, there's what's called primary and secondary impingement. Secondary impingement is stuff that you and I can treat. Primary impingement would be like a type 3 acromion, where you have like a structural like beak to your acromion. So every time you lift your arm, that beak is diving into the supraspinatus tendon. Another real common one, primary impingement, would be you have degeneration of your AC joint, and one of the osteophytes that's hanging off that is now pinching down in the supraspinatus. So these people do really, really well with the decompression. How I usually get to this point is I'm 3 weeks in with them and they're telling me they're exactly the same, which is a little bit rare. If you're doing good treatment and they're not any different, that's odd. So that like lends me to believe that maybe this is a primary impingement and that maybe we need to do a surgical decompression. They just basically go in with a Dremel tool and knock off that degeneration, and the patients really do really quite well. And then I also think that like, for example, if you're a CrossFit athlete or Olympic weightlifter and you have a type 3 acromion, you may actually do a proactive surgery to burr that off, because over time, that structure of your shoulder will destroy your supraspinatus tendon.
Ooh, my turn already. Okay, so we're going to talk about babies, classically, because that's what I love so much. So in the first year of development, the goal is joint centration, so the joints can form appropriately. So what I mean by that is the muscle pull around each joint has to be optimal. So in a well-developing baby, at 3 months old, if you put them on their belly, this is what they're going to be doing. So they're going to be supporting through the elbows and able to upright the spine and turn the head both ways. So this is the first time in development that they're doing something with on purpose, with a purpose, from motivation. So tummy time, right? We hear that all the time. Tummy time is important. This is classically why. So right now we're just going to talk about the shoulder, obviously. But in this position, the serratus anterior is actually lifting the trunk up into the scapula. So it's kind of reversing the way the serratus anterior actually works because of the support through the elbow. So because the humerus isn't moving and the scapula is not moving, the support point is the elbow, like I said. And then because of this, the biceps and triceps on the support arms, they're also kind of steering the scapula. So they have to go down towards the elbow, and they're kind of doing this motion on the scapula itself. And then the rhomboids also are pulling the trunk toward the scapula as well. So again, this is just like the first time the shoulder is getting joint centration on purpose from child development and forming that joint.
This is also in DNS, so like in any shoulder case, like if we do a good assessment on them, we determine that we want to start a scapulothoracic stabilization program. Every single time I'm starting here, like I can't even think of when I wouldn't, but so this is, if we're talking about treatment for a second, like this is also the position we start with, because the patient's also hopefully at this point been taught how to generate the right intra-abdominal pressure in their belly. Like Lauren said, we're reversing the pull of all the muscles. So that's a really, really important point, because now we're talking about closed kinetic chain function. And that's different than most people, or even like traditional rehab of the shoulder, where someone would be laying on their side doing an open chain exercise. So now we're pulling the muscles. We basically flip the origin insertion on itself. Just as another pediatric note, if they're at 3 months of age, the humerus in the torso, if you drew lines here, and here, at this age, that should be a 90-degree right angle. So that's one way, like if you're looking at a baby and you're wondering if they're developing in the way that you want them to, that we can look at from this position here. And then if Lauren was on a glass table here right now, and you looked up, you would want support on the medial epicondyles and the pubic symphysis. So those are like the key support points, as long as we have the right stabilization. As you can imagine, you take some random person and put them on a table who doesn't know how to stabilize well, the support point will be their abdominal wall, not their pubic symphysis. But if we have the right intra-abdominal pressure and we have the right spinal mobility, then we can get these correct support points.
Exactly. Yep. And then another key point of development for the shoulder in particular is 5 months side lying. So around 5 months of age, babies will begin to realize that they have another side to them. So but what I mean by that is the corpus callosum starts to close in the brains. They're actually aware of both sides of their life. So they start to roll. So I'm sure we've all seen a baby roll. If you haven't, Google it. It's really cute. And they do this exact pattern. So they're going to support through the elbow again on their side with their arm up like that. And then the same kind of thing happens here for the joint to be centrated, the shoulder. So the humerus is not moving in this position, but what is happening is that the serratus anterior and the pec muscles, major and minor, they are helping the trunk with the scapula to rotate over the head of the humerus. So this is a good eccentric activation of the external rotators of the shoulder, again, for proper joint centration and the formation of the joint in the first year of life.
If you ever go to a DNSB or Exercise 2 course, we basically the whole weekend is about exercising from the position that Lauren's in right now. So this is, probably the second go-to exercise we use in DNS after we usually start with 3-month prone, as we just showed. And then this 5-month position here is really, really, really good for activating all the muscles around the shoulder girdle also.
Yeah, and I think the other important point too, this is where you start to develop depth in your socket. And so this is where, like, starting out the building the shoulder, like Brett was talking about with the dislocations and stuff, this is where we start to get depth so that we're hopefully not as susceptible to those types of things.
Exactly.
So, all right, so onto assessment. So we always, Brett and I talked that I think we've shown this picture, I don't know, a million times at Logan. Yes, and so I think it's really important. We always talk about, there's obviously downfalls in the study. There's some issues with it, but the more you see patients, the more this is going to come true for you. And so we're talking about the shoulder today, and I would just beg you, especially shoulder blade pain, that medial scapular border pain. I would say that it's 90% of the time, maybe even more. It's coming from the spine. And so whether that's the front of the shoulder, any type of pain in the shoulder, do your due diligence, roll out the spine, do a really, really, really good mechanical exam on the spine before you move on to the shoulder. And sometimes if you move on to the shoulder too quick, you can always go back to the spine too. I think that's another important point. Yeah,
there's 2 references for you there. One is Clower, the other is Klussage. And basically they both were able to determine, like, the disc of the cervical spine is able to refer pain around the shoulder blade. So even myself, I kind of like mistakenly thought that the referral was always from a nerve root, but actually the disc within itself can send somatic pain around the shoulder blade. And so that's like one thing that I've really learned in the last 5 years as far as like referral of pain. It doesn't always have to be nerve root or trigger point. Like there can also be somatic pain from structures like the disc around that area. And I think a lot of people, even the surgeons around me, they get that confused also. So most people think like it's the disc is sitting on the nerve. That's what's giving us pain here. But according to Klussage and Clower, like it's been proven that the disc within itself can send pain to the posterior shoulder blade.
Yeah, it's pretty amazing. So assessment. Looks like one of my pictures got Okay, oh, there we go. All right, so Brett kind of talked about them. So this is just like a little reminder if you haven't seen these. So empty can, obviously we should probably know that one. But then the other two that we're really going to focus on as far as orthopedic tests is going to be clunk and grind, which is going to give us a decent idea of the integrity of the labrum. So basically what you're doing is you're loading down the humerus into the glenohumeral joint, and then you're just internally and externally rotating. You're kind of looking for a reproducible click or a pop. It's going to give you an idea of whether or not there's fraying in the labrum or if the labrum is the actual pain generator.
Can I add something?
Yeah.
So one thing to watch on that, like a lot of times people have clicky and clunky AC joints. So oftentimes had students think they've had a positive test on this, but it's really their AC joint that's clicking. So how to get around that is, one, put your thumb over the AC joint. You see where Taylor's left hand is? So you can put your left thumb over the AC joint to stabilize it, to remove the click and see if that takes it away. The other thing is that also can just palpate it. That way you know that you're dealing with the AC joint clicking and clunking around, which is quite common.
Even like the bicep tendon clicking over top and stuff like that. So, and then the one on the right, I think, is the best one for your money, which is we kind of talked about Dr. Andrews being the first one to really start talking about the slap lesion. This is his test for a positive slap lesion. And so you're going to abduct the shoulder completely, and then you're going to passively introduce internal rotation at the top. And so it's going to be painful, is kind of your best positive test. But I would also say, too, that just because this PET test is positive does not necessarily mean that it's they need a surgical intervention or anything like that. This is an amazing audit, especially like if you're really into MDT or into mechanical assessment. This is one of my go-tos with a positive Andrew slap test, and then reorganize the tissues with the mechanical load, which we'll kind of get to, and then come back and retest this test, and you can make some big changes.
So when I was in school, we were taught the O'Brien test, as I'm sure you have too. And I have never been more frustrated with any test in my life than that test. And I remember talking to the orthopedic surgeons around me at the time being like, do you guys like this test? Because it was supposed to have such high sensitivity and specificity. And everyone was like, no, that's horrible. When they did research on it, they showed like it was like 90% specific and sensitive. So then, and then Jurgensen's was supposed to have like some credence also. But so then basically now those have been done away with. And basically what they did with this Andrew slap test, they took a bunch of people who had a slap tear, and basically he sat down with his fellows. One was in St. Louis, who I know. And he said, okay, we know these people have a slap lesion on their MRI. You guys go find a test that is reproducible on every one of these people. And they came up with this test here. So I might need to just kind of quickly say exactly what we want to do. You want to load back through the humerus. So you see Taylor on the far picture to the right there. He's abducting to 180 degrees. He's now loading the humerus back into the glenoid, and then you give passive internal rotation. And it is purely a test, not on clicking or popping, but to see if you reproduce their pain. So that is a really good test for the slap lesion. The other one that's got a little bit of decent research is your resistant uppercut. So basically you put them at a 90-90 like this, you block upward motion, and you have them like they would be doing a punch like this. And we see if we're able to reproduce their pain.
Roll. So then as far as like a mechanical assessment, and so obviously this is straight stolen from the MDT land, but so basically what we're looking for is range of motions. We're looking for asymmetries. And so whether or not you can find an asymmetry in here, a loss of range of motion, or even a painful range of motion. But if we're being honest, like if we're looking for a directional preference, it's going to be the one that has the biggest loss of range of motion. And so for the majority of the time, especially people are going to respond to either extension or extension internal rotation, it's going to be just straightforward flexion. And so you're going to see a big old asymmetry in there. Sometimes you have to give a little bit of overpressure to kind of tease it out. And then the second most common one is reaching behind the back. And so, if with our aging population, if we're looking at adhesive capsulitis or those other types of shoulder issues, that's going to be like the first sign. It's usually female predisposition, and they're going to say, I have a hard time hooking my bra. And so, maybe Brett can talk a little bit more about the functional medicine side of this, but if you do see that, especially in the female that's not coming around, that's maybe in that freezing stage of the frozen shoulder, there's always an internal reason for that. I think it's diabetes, thyroid, and female hormone. So those are the top three labs that you're going to look at. So
it's, so they have limitation in the motion Taylor's doing right there, internal rotation. I'm talking severe limitation. That really the only thing that does that is adhesive capsulitis, especially in a middle-aged patient. So really the diagnosis is quite simple, but in a differential diagnosis, what sometimes can be hard, ironically, is a rotator cuff tear versus frozen shoulder. So here's a good clinical parole for you. If you have a full supraspinatus, full thickness tear, you can still do that motion Taylor's doing right now. If you have frozen shoulder, you're unable to do that. If you have frozen shoulder, you have strength on an empty can test. If you have a full thickness supraspinatus tear, then you don't have strength there. So real quickly, you're able to kind of sort through that. So I have the utmost, I guess, respect, if you will, for functional medicine. So like then at that point, I would order the right blood work. And then, then we would start treatment on the diabetes, whatever it might be. It's the best example that exists for a viscerosomatic reflex or response, meaning you have something that's wrong in the metabolic system that's manifesting itself in the musculoskeletal system, which any catastrophic visceral problem you can name me will manifest itself in the musculoskeletal system somehow, some way, through trigger points, tension, tone, whatever it might be. But frozen shoulder is probably the best example of it that we see in the body. So you want to be sure we treat people with frozen shoulder from a musculoskeletal standpoint, but we also want to be sure that maybe you've diagnosed a Hashimoto's disease, or maybe you've determined they're a type 2 diabetic, whatever it might be. But it's important that we're able to do that for them.
The other thing I would add is this is actually a pretty sensitive orthopedic test too. If you're suspecting the AC joint, this motion right here, end range adduction. So I treat a ton of the football players in the area. And so this is a pretty common injury at the end of a football season, tons and tons of shoulders, especially in the line. And so if they get pain over their AC joint in the end range adduction, you have a pretty decent idea that the AC joint is the pain generator versus if it's a mechanical thing or a rotator cuff issue.
With the new standards for football hitting, where they're not allowed to lead with their helmet anymore. So we've had less reported concussions in TBI. However, we have more AC joint separations because now that they're leading with their shoulder, then we're seeing a lot more AC joint problems than we ever did. So it's kind of a trade-off, but I guess I'd rather have a bad AC joint than a concussed brain.
Well, yeah. 6.5 dozen in that.
As far as like what he said on like the miracle McKenzie moves for the shoulder, extension and behind the back internal rotation is where a lot of the miracles occur. And the reason is because our shoulders typically don't go into these motions every day. So you could argue during Paleolithic times that all our joints got taken to end range almost every day of our life. And now because of sedentarism, our joints just don't do that. So our shoulders, for example, basically live in a very small range. And because of that, a lot of times we get really stiff. So if we want good lubrication of our synovial joints, we want to move them into their full range of motion whenever we possibly can. So in saying all that, as you can imagine, when's the last time your shoulder was an in-range extension like Taylor's showing right now? So because of that, it's just an explanation for why a lot of times we get miracle results by just simply moving a joint into a position it's not used to being in. What Taylor's showing you there is no different than a press up for a low back. The miracle in a press up for a low back and MDT is just simply that we all sit with our low backs flexed all day long. So then we take our joints into the opposite motion, and because our joints are never in that motion, it actually likes it. So that is the reason or the explanation why.
Definitely. So the only other real functional test that I enjoy, and honestly, the reason I don't do more is because in this my mechanical assessment, I can kind of get a decent idea of whether or not we're getting rolling at the glenohumeral joint and the scapulothoracic rhythm as they're going through these motions. So I'm kind of just bucketing everything to one and trying to find what the biggest case is. So and then I just have them go quad rock, which is kind of from the DNS world, but it's come from all over the place really, and just seeing if they can adhere their scapula to the rib cage. So along the lines that Dr. Jordan was talking about too, of the scapular stability, that's the name of the game. And so this kind of really teases out, along with like loading to the hands, and can give you quite a few answers through there.
One real important point, if you're going to do scapulothoracic stabilization, you've got to already have the conversation about intra-abdominal pressure with them. So you have to have stabilization between your rib cage and your trunk to get ideal stabilization between your shoulder blade and your rib cage. And if you ever wander into a DNS course, I mean, that's like a big part of, on what we teach on that. So it is an epidemic problem to see scapulothoracid instability, partly because of the way people train, but also partly because posture. So in the hip, Jan used to talk about tight hip flexor will inhibit your glutes. In the upper quarter, tight pectoralis major will neurologically inhibit your serratus anterior. So you're always kind of dealing with these muscle imbalances in every single person who's walking around on planet Earth.
Definitely. Okay, so we talked about MDT, obviously. So those are kind of your two miracle movements, a little clinical pearl there for you. And then I just don't want us to forget some of the most important things. We always joke our favorite thing to do in the world is adjust, and so proper cervical thoracic motion is actually really, really imperative for shoulder function. Right? Nice. I just have to always add that.
Gosh, that was slow.
I'm crunchy, so they always use me.
So the other thing I would say, like even like if we looked at tennis elbow or lateral epicondylitis, it has been found that if we just do in isolation CT junction mobility with these patients, that paper was done by a guy named Cleland, that we will have a better outcome than if we didn't do that. So it's just important to remember that spinal mobility, whether it's a disc herniation or not, is always important for integration throughout the whole kinetic chain of joint motion and your ability to turn certain muscles on.
Definitely. So we're all MPI homers, and so adjusting is a major component of what we do, and I think why we get pretty good success. So learn how to palpate and adjust.
Okay, so with the time we have left, we thought we'd just kind of talk about like biomechanics and techniques of throwing. So I'd be remiss to say that, if you're really good at treating the shoulder, then everyone's going to get better, because there's this other part that no one wants to talk about, which is that biomechanics actually do matter. So you can be stabilizing your shoulder exactly in a perfect way. And if your biomechanics of throwing a ball or a javelin or whatever it might be are off, then that is also a way that we can hurt the joints around the shoulder girdle. So the term that I like, and I'll tell you why I like this term, it's serial stabilization, which basically means each stabilization is kind of building on itself throughout the body. So if we look at a throwing athlete, we have the ground reactive forces and the stabilization that's occurring through our lower extremity. We then need to stabilize our trunk in the right way. Then we need scapulothoracic stabilization. And then if we throw something well, basically there's no tension in the upper extremity. All the acceleration is occurring through our kinetic chain or through our body. And then the arm is literally a whip that's along for the ride. So the forces that are going through the glenohumeral joint, and for example, throwing a baseball, they're the most destructive forces that are in any sport, which is kind of hard to believe. So if you look at here, the shoulder is going 7,500 degrees of internal rotation per second. It's the fastest motion that occurs in all of sports. That is why I've looked at more people throwing a ball than anybody else. I don't know. I've seen a ton of it. But even at this point, I can never just walk outside and say, okay, let me see you throw a ball. It's still, for my eye, which is well trained, it's still occurring so quick that I could never in a million years do it without video. So anyways, but the forces are drastic. And if you look at this, so it can be 1,270 newtons of force, which is about 280 pounds of pressure. So the analogy, and it's not an exact clean analogy, but it just gives you an example. If you swung a 280-pound kettlebell, at the moment that you were swinging it, the amount of distractive force that would be occurring through your glenohumeral joint is that would be occurring with throwing a baseball. So that is where, at least when we teach DNS baseball courses, we believe that your central nervous system ability to activate all the muscles around your shoulder girdle at this moment is so important. If it's not the way that we want it to, then bad things obviously can happen. That can be an elbow problem, or that can be a shoulder problem. One thing that we're dealing with, and this study was on handball players, but it's actually one of my favorite papers because it actually exposes that load does matter. So in this, they looked at external rotation strength, scapular dyskinesis, and just like the drastic change of environment or load on these handball players. And in baseball, this is a huge problem. For example, maybe you're in the minor leagues, you're used to a certain routine, you get brought up in the major leagues. Well, now your load drastically changed, either less or more, depending on the current situation. So obviously, when they looked at the research on this, although scapulothoracic mobility and stabilization mattered, and although external rotation of the strength also mattered, the biggest risk factor was a huge change in load. And I think that's a really, really important point. And I spent, when I was heavily involved with Major League Baseball, with a Major League Baseball team, I was always trying to educate them on that thought of like, we need to watch that we're not drastically changing their load, because that is one of the biggest risk factors for them to get injured. Also, like on people who tear Achilles tendons and patellar tendons and things like that, tendons don't like a drastic change in load. That's why you hear a common thing of, I basically sat on a couch for 10 years. Now I'm 35 years old and I go play basketball with my buddies and I tear my Achilles tendon. So we always want to like slowly increase load no matter what we're talking about to help prevent injury. I feel like we could just spend the next 5 hours talking about this slide, but I'm going to try to keep it simple. So on the picture to the left of the javelin thrower, this is utilization of what's called the anterior oblique sling. The posterior oblique sling is also very, very important. But if you made me say, what is one of the huge attributes that Major League Baseball pitchers have, it's their ability to get stretch and activation out of the sling. One way to think about it is if you took this anterior oblique sling that you're looking at here, and I'm showing you with the cursor here. So you have internal oblique, rectus abdominis. You, of course, have the fascia of the abdominal wall, external oblique, pectoralis major. It is this sling that is so critical for throwing things. Now imagine I put a rubber band instead of this sling here. So I put a rubber band on your ASIS and I attach it to your arm. I want to get as much stretch as I possibly can through this rubber band. So now you can see kind of the downfalls of having a trigger point in your pectoralis major, for example. So if you're dealing with a Major League Baseball pitcher, you are going to take your treatment to that level because that trigger point is actually robbing them of more stretch here. Now, of course, that doesn't mean I'm just going to dry needle that trigger point. I'm probably going to turn the muscles on around the shoulder blade to reintegrate that trigger point and to allow them to be able to get that pectoralis major to relax. Now, the other critical point in throwing sports when you're talking about timing is here. Notice that the athlete has the forearm in a relative decent position. Just notice that, because I'm going to show you in a picture here in a second to show you why that's so important. So meaning the upper extremity is in a really neutral position at that point. The other hallmark of great throwers is you have not rotated too soon. So if you look at this javelin thrower's left foot, it's about to enter the ground. When it does enter the ground, I need that torso and rib cage to still be facing third base, if you will, to keep going with our baseball example. People who do not throw objects well, which is probably everybody who's listening to this right now, including myself, meaning like you're not world class at throwing something, you are probably starting to rotate your trunk a moment too soon. And what that's doing is it's taking stretch out of this rubber band that I'm talking about. We see the same thing with hitting. So as you transfer your weight in hitting, you've already started to rotate your trunk too soon. Same thing in the golf swing. You're in the backswing. When you initiate your downswing, you've already started the rotation. So this is another probably good clinical pearl to take away from. If you want to be world class at a rotational sport, you cannot rotate your trunk too soon. And if you do, then you are robbing yourself of this elastic stretch that I'm talking about right now. So, and it goes without saying, this is another really important tenet of DNS. We can talk about the big superficial movers and muscles all day long, but if you don't have them anchored correctly with the right intra-abdominal pressure below, it's like having all the money in the world and you don't have an ATM to get to it. So we always want to be sure these, another way to think of it is not just for performance, but also like destroying your own segments. So if I'm exploding these big, powerful muscles off an unstable spine, then obviously I'm going to hurt myself. So these are good. These are my two favorite. If you're into baseball, these are the two best mechanical pitchers from the DNS standpoint that I've ever seen. Tom Seaver and Roy Oswalt. And I'm being told to wrap this up. So give me 1 minute and we'll be done. So you can see their forearm is vertical to the ground right now, okay? They had awesome, healthy arm careers. You look at these people, they did not have good arm careers. When the foot is entering the ground, if you look at their forearm, it's actually parallel to the ground. And you don't have to, have a brain to look at these pictures and notice that their shoulder is not in a good position. If you look at Billy Wagner from the Mets here, I mean, that is basically the orthopedic test for impingement. So you can see, even with an untrained eye, that these are not good positions. And of course, they all end up injured. So, but anyways, like I said, we could talk for days about this. And we do in DNS baseball if you ever come to a course. That is all I have. I guess we'll wrap this up. Thank you so much for having us. I don't know. I feel hopefully we didn't just tease you. I hate things like this that you feel like all they did was tease a bunch of other stuff. So I hope you did get some clinical pearls from this. The shoulder is actually the third most common reason a patient's going to come see you. So it's a great niche to have. Obviously, low back pain's 1, cervical spine's 2, and shoulders 3. So thank you for spending your Friday with us. And closing thoughts.
So I don't know if did the chat come up with any questions or anything like that?
So no questions in the chat right now. I don't know if people want to stick around, if you guys are willing to stick around, but feel free to throw up any questions you guys have, if these 3 are willing to stick around. But again, thank you 3 so much. If any of you have the opportunity to get down there or to a Gestalt course in general, I would say don't think about it, do it. I was there in November, and it was potentially the most valuable 3 days of my seminar career. So these guys take good care of you.
He just came for the happy hour. That's why he.
Well, if you're good at bags, then
cornhole.
Cornhole. Then we want you here because we think we'll wreck you in a game of bags. But we'd love to have you.
Yeah.
Make sure to bring Brett.
Maybe some speaking about what we have going on in the meantime. So we had DNS swimming in your backyard at Stanford, but unfortunately, because the pandemic going on right now, that got canceled. So coming up, we do have DNS weightlifting with Rich Ohm. We've got a couple DNS courses with Brett, TMJ, Michael Shacklock for neurodynamics, which is probably my favorite weekend of the year. It's 4 straight days of Michael Shacklock dropping complete bombs, and he's just a good dude in general to hang out with. So, yeah.
Lauren, any closing thoughts?
I guess getting in contact with us if you do have any questions that maybe you didn't want to. You email team.am@gestaltedu.com, or look us up on social media. You can DM us and do anything like that. We'll try to get to it as soon as possible. I'm not exactly the best at getting back to people, but we're trying to do a little bit better. And otherwise, stay tuned for some social media stuff. And if we can help you.